Okay, hello everybody. Thank you all for joining us for this session on coming of age with HIV, a testimony of our success and a measure of our readiness for the future. We'll start by, I'll frame a little bit about the session, and then we'll do some introductions for our speakers. We'll also subsequently have a panel, and this session is really designed for us to have time for discussion and engagement with all of you. Thank you so much for being able to be here. This is the first time that at least I am aware of that at the International AIDS Society Conference, we have brought together what our speakers have called the first 20 and the last 20. We talk about cascades a lot and in our field, and this is looking at older children, so adolescents, and older adults, all the way into aging. And it's given us the chance to bring both sides of that spectrum together. So in this room right now, we have pediatricians and we have geriatricians. We have people who are advocates for the young and people who are advocates for the older. And so we're very pleased that you could be here. And what we're going to do today is have talks that talk about different aspects of chronic diseases and challenges that people living with HIV are facing as they get older in these two differing demographic populations. We'll also have reflections from panelists who will talk about what the speakers have shared in terms of clinical data, models of care, experiences living with HIV, and then we'll open it up for discussion. So we'd like to go ahead and introduce all of us here, and I'll start by introducing my co-chair, Kate Thompson. Kate is the head of the Community Rights and Gender Department at the Global Fund to fight AIDS, tuberculosis, and malaria. Kate has more than 30 years of experience working with civil society and communities, with a focus for much of that time on those communities most affected by HIV. In the mid-1980s, she helped to establish Positively Women, now known as Positively UK, one of the first organizations of women living with HIV globally. And in 1992, Kate took on the leadership of the newly established International Community of Women Living with HIV. Those of you who attended the opening ceremony may remember a very moving tribute to ICW. And in early 2002, she moved to Geneva to join the Secretariat of the Global Fund, where she worked as the Civil Society Relations Manager. In 2005, Kate joined UNAIDS, where she stayed for 8 years, leading their work in civil society partnerships and community mobilization before returning to the Global Fund in 2013 to set up the CRG, or Community Rights and Gender Department. So we're really happy to have her here, and now Kate's going to introduce me.
Thanks so much, Annette. And it's my great pleasure to introduce Dr. Annette Son, who's the director of AMFA's Treat Asia program based in Bangkok, Thailand, where she oversees the implementation of HIV research, education and training, and community advocacy and policy activities in the Asia-Pacific region. Treat Asia's research is conducted in collaboration with a network of over 60 adult and pediatric clinical sites in 14 countries across the region. Her primary interests are in studying HIV clinical and program outcomes, with a particular focus on adolescents. She's also an associate clinical professor in the Department of Pediatrics at the University of California, San Francisco.
And so I will introduce our first speaker. Dr. Tanya Wee-Putanikid is an associate professor and a pediatric infectious disease specialist at the Department of Pediatrics, Faculty of Medicine, Chulalongkorn University in Bangkok. She's a former trainee of the Johns Hopkins University Fogarty AIDS International Training and Research Program, or ATERP. She started her clinical research in pediatric HIV/AIDS, focusing on ART in resource-limited settings in 2002, and is a leader in pediatric HIV treatment and care in Asia. She leads several multi-center research projects in Thailand, Cambodia, and Indonesia, and also collaborates with my program. She has over 100 peer-reviewed articles in the field and has served on the writing committee for WHO's Pediatric HIV Treatment Guidelines and Thai National Guidelines. Her current clinical program is focusing on transition of perinatally HIV-infected children from pediatric to adult care, and also providing HIV prevention and treatment services for young adults who have been recently infected. So, Dr. Tanyui?
Good morning and sawadee ka, which is the Thai greeting. It's my great honor to be here today to talk about chronic disease in children and adolescents on antiretroviral therapy, preparing for what is to come. Because the first thing is that we now talking about preparing newly infected children to have a happy and healthy life when they get older in their elderly period. So it means that we're expecting normal life expectancy of newly infected HIV children or children and adolescents living with HIV. And when I talk about how it's growing up with HIV, this is the painting from our children in the clinics that they are looking for the bright future. So let's start off how we can prepare the bright future for these children. I would like to talk about the chronic disease in adolescents, which is just an example of the conditions that I pick. The first one is atherosclerosis vascular disease risk, because it's the example of the conditions that will be subclinical in the first 20 years of life, but it will manifest later on when get into adult or elderly period. For bone health is the example of the conditions that we have window of opportunity to do it right during adolescent period, because we know that the majority of the bone health is accrual during the puberty period, so we have the window of opportunity that we should do it correctly. And the third one is on the mental health issues as an example of the conditions that actually affect adolescents in general, irrespective of HIV conditions. So it's remind us that we should have a point of view how to approach this as a general health, not double stigma, patients who have HIV adolescent plus mental health issues. And the third one is on cognitive and executive function of the brain, because adolescent is the period that they're still working on development on it, and also it will be affect the ability of the self-care, and also will link to the period when get elderly, whether it will be declined cognitively faster, and if it does start off with impair, it might be double age that has problems on how to self-manage. So I would like to talk about what is the prevalence of it, how common of these conditions, how we can screen, prevent, and manage these conditions. Start with the atherosclerosis vascular disease risk. This data show from the meta-analysis from almost 800,000 HIV-infected individuals, showing that HIV-infected individuals will have 2.2 times risk of atherosclerosis vascular disease risk compared to HIV negative. And why this happened? There are two parts of pathogenesis. The first one is on accelerated atherosclerosis from HIV itself, from chronic inflammation that cause endothelial dysfunction or increase arterial inflammation. And there are some subclinical parameters that we can measure, such as increased common carotid artery intimal thickness among HIV-infected individuals start during adolescent period, and also other mechanisms such as thrombus formation, which we cannot measure. And also another part is on traditional risk factors, that anyone can have these factors that contributing to the long-term atherosclerosis, such as dyslipidemia, which in general, it might be different from each region. For example, from the US cohort, about 20% of adolescents in the clinics have dyslipidemia. In Asia, about 10% that have high cholesterol. And also other conditions, hypertension can occur. Do we measure blood pressure in our clinics? Hypoglycemia, smoking, and obesity. So I think it's not time that we expecting clinical events of myocardial infarction or stroke in the young, but we should thinking about how we can do risk reduction at the first hand. The first things that we can do is to access to antiretroviral drugs early on and make sure that during the maintenance phase, which is a decade of many years, that we can have safe maintenance drugs. We know that the boosted PI class is a class that is associated with dyslipidemia. So if we have a better class like integrase, it might be help to reduce long-term risk. The second part is on the general health promotion, like no smoking, exercise, or diet modification. And the other end is that in cases that have extreme problem that cannot solve with these tools, we might start thinking about pharmacotherapy. But there are still limited data on how statins can be used in HIV-infected adolescents. There are some data from US, from the IMPACT P1063, starting to use atorvastatin in children with high LDL cholesterol. In that study, 2/3 of the population can achieve targeted LDL that they want. But the problem is, what is the long-term effect? How many years that we should give on statins? So it's better off try to have safer drugs and have a healthy lifestyle. And I talked to colleagues from Africa. The smoking is also a problem for parental smoking or smoking in the families that might affect children early on. So the next one is on bone health. You can see in the slide on the spectrum of bone development. You can see clearly that during adolescent period, during the puberty period, 40% of bone mineral content acquired during puberty at the age around 13 to 14 years and 4 years after that. So how to make it right? What we can learn from Amsterdam is that, you know, that Netherlands is the country with the highest adult height in the world. They do biking, physical activities, cheese that have calcium or vitamin D. So I think this is the basic health promotion that we could make sure that adolescents growing with HIV have adequate physical activity, calcium and vitamin D, to make sure that have adequate bone health. And the one that have negative impact is on contraception using DMPA or some long-term HIV infection. So the children that experience the severe immunosuppression or malnutrition also have osteopenia in much higher percentage comparing to the children who access to treatment early on. And also some antiretroviral drugs, such as tenofovir, also have effect on bone. So this is the data from different parts of the world. When we look at bone health in adolescents, we talk about osteopenia. We are not at the stage of osteoporosis yet. So the osteopenia definition is have bone mineral density C-score less than 2 C-score comparing to the same age and gender, using the dual energy exeraptometry or DEXA scan to measure it. And this data showing that in the US and Netherlands, only less than 10% of adolescents have osteopenia. But in Thailand or Brazil, about 20 to 30% have osteopenia. And why is that? So we go back to the basic of what is the contributing to the bone health. And it's showing that in the US cohort, even in the US, the average calcium intake is about 700 milligrams, which actually it should be 1,300 milligrams per day. In Thailand, it's even worse. The average calcium intake is less than 300 milligrams, and also true in South Africa. So should we give calcium and vitamin D supplement? This is not a treatment, but just supplement to make sure that they have adequate nutrient. And this data come from ATN study from the US in adolescents who taking tenofovir. They start off with quite a good bone mineral density. If we give just a vitamin supplement at a minimum level, like calcium of 160 milligrams plus vitamin D every month, by 1 year, we can see the increase of bone mineral density only 1%. But how about the settings that they start off with osteopenia? I just picked 2 examples from Thailand that we are working. If we have a subgroup of children or adolescents who start off with osteopenia, have bone mineral density lower than -2, and we give quite adequate calcium intake. So 1,200 milligrams per day, coming in terms of the supplement twice daily for 6 months, is show that they are significantly improved bone mineral density from -2.6 to 1.7. And we're also testing dose response. If we increase dose of vitamin D, do we see the better effect on bone density? We also see the dose effect, that if we give supplement of vitamin D weekly, we also have better off of the bone density. So the challenge is that we don't have bone mineral density scan everywhere. So the research question that remains to be taken is, if we know that majority of adolescents, especially in low-middle income countries, don't have adequate calcium and vitamin, is it worth to give everyone a supplement, and how it will affect on the bone health? Because vitamin D also have another aspect have to be concerned is on the risk of cardiovascular. The next one is on mental health among adolescents. And this is a broader context of how we're taking care of adolescents in clinics. Usually we will have small talk, which we will assess, it's called HAEDS, home, education, eating, activities, drugs, sex, suicidal, and safety, as a simple way to assess general health, the same as we focus on weight, height, or developmental milestone for young children. And we take history of this, we can detect depressive symptoms. If adolescents don't want to eat, don't sleep well, don't hang out with friends, this is the symptoms of depression. And the next question that we should also ask is suicidal ideation or suicidal attempt. And if you don't have time to do that, you can also implement a simple mental health screening test, which is about 9 to 20 questions that you can do while the patient's waiting in the clinics. Try to triage person who have problems. And depression is silent. It means that the patient cannot come to talk to you that they have depression. So we have to screen. And on average, 1 out of 10 patients in the clinics have mental health that waiting for us to detect and do some intervention. So this is the data from different parts of the world that try to use simple screening questionnaires. They use different questionnaires. But in general, what we see is that about 10% had depression or mood disorder, and about 10% have suicidal ideation. So we don't want to lose our patients because we couldn't detect suicidal ideation or suicidal attempt. But one might argue that how are we going to do that in the clinic that is very busy? And I have a chance to talk to colleagues from Zimbabwe, and in Zimbabwe situation, the ratio of psychiatrists is 1 per million population. It's no way that you can do formal psychiatric assessment. So they do task shifting, the same as we do task shifting when we're starting to talk about ARV rollout to millions of people. They ask grandmas who have life experience, have love, and have time to listen to set up, it's called friendship bench, that you can sit with a trained grandma to do a problem-solving therapy and peer support. And they conduct study in 2014-2015, and 40% of the client is HIV positive. And after 6 months of intervention, it's shown that the significant less depressive symptoms among participants, about 14% compared to 50% in the control group. And not only the problem-solving therapy or cognitive therapy, another one that we have to thinking about is on the medications, because we know that depression or mental health, part of it is from chemical in the brain. So we have to start thinking about whether we can supply these drugs in the ARV program. And the last one is on the cognitive and executive functions for adolescent, because adolescent is the still period of brain development, in which the period of limbic regions of the brain, which control emotions function, is developed ahead of prefrontal regions, which is the logical thinking. So it might be the time that they start to involve with smoking, alcohol, or some predisposing factors for the long-term chronic conditions. And also this, the study on the cognitive and executive functions that we presented by our groups on Thursday, that we try to measure the cognitive functions of growing adolescent. This bar represents the HIV positive population. The green one is HIV exposed and infected, and the blue one is the control group. You can see that the prevalence of impaired cognitive and executive functions in HIV positive adolescents is about 2 to 3 times comparing to HIV negative control. So if they start with cognitive impairment and with the chronic conditions, you might have problems when they're getting older and get into the period of cognitive decline. So what is the research gaps in NCDs in low and middle income countries? This nice review article supplement on AIDS is talking about how we prepare NCDs integration in the ARV rollout clinics. There are different levels that have to thinking about the service delivery models and what is the NCD diagnostic test and medication should be available in low and middle income countries. How are we going to triage and identify patients at high risk at a minimum work because we know that it's overwhelming how we can integrate NCD into the HIV workflows that is not disturb the quality or the time that we can spend on ART. And also what is the training modules that we should build for healthcare workers and also community to help, for example, of mental health, that we need community to help and handle these NCDs. So while we're waiting for more research and data, I think what we can do now in our clinic when we go back to our work. We should make sure that the children and adolescents and every HIV-infected individuals can access to metabolic-friendly airway regimens, health promotion using community approach, smoking, simple tools to screen NCDs such as hypertension screening, obesity by just do waist circumference, or mental health screening and task shifting to someone in the clinics, layperson or the team members to help to screen, detect, and help someone with mental health problems. And also started thinking about supply chain for non-antiretroviral drugs or non-OI medications, such as vitamins, calcium, or even folic acid in the era of the dolutegravir with consequence in pregnancy, or medications to treat mental health in the services. And I would like to conclude that HIV comorbidities are manifesting in decades to come, which is a good news because we know that we're expecting normal life expectancy for HIV-infected children. We should minimize HIV-associated risk by early ART and also safe drugs for maintenance period. We have to make sure that we go out of HIV virus and see them as a person. We need to make sure that they grow up and have maintained adequate nutrients, physical activities, and childhood life. And also mental health is also an integral part for adolescent care. I would like to end my talk with another painting from our young gentlemen in the clinics that they are looking for future. I would like to have family, house, rice farm, money which I earn for a living, and I'm in a promising way of hope. So I think we can help them to have a promising way of hope by not only see the virus or treatment on the HIV, but also have to prepare them to have a healthy and happy elderly life in the next decades to come. Thank you.
Thank you very much, Dr. Tayui. I think we'll save the questions to the panel discussion at the end, and I'll turn over to Kate to introduce our next speaker.
Thank you. And I'm delighted to introduce Luis Mandau from Portugal. So Luis concluded his studies in biochemistry in 1983 at the Université Pierre et Marie Curie in Paris. Luis is currently chair of the board of GAT, Treatment Activist Group, which is an NGO founded in 2001 and working in prevention, early diagnosis, treatment and care of HIV/AIDS, viral hepatitis and tuberculosis with a focus on key populations. He is also the founder and on the board of directors of the Portuguese Drug Policy Reform Association, SOMA-APA. I'm not sure if I'm pronouncing that correctly, but Luis is a member of the European AIDS Treatment Group, EATG, and a former chair of the board 2016. It was also, Okay, so yes, sorry. So he was also twice the co-chair of the HIV/AIDS, Viral and Hepatitis, Tuberculosis and Civil Society Forum of the European Union until July 2017. And since 2005, he's been a community consultant at the World Health Organization Europe, WHO Europe, EMCDDA, ECDC, and EMA. He was ordered commander by the President of Portugal in 2014 for his services to the community and to public health on HIV and viral hepatitis. It's my great pleasure to introduce you, so please come to this stand.
So after this presentation, I'm very worried that I will disappoint you. And I would like to know all these things. So before starting, I must say that I'm very happy to be here in Amsterdam to 23 years later, that I supposed to be killed because I had, when I was diagnosed, 2 CD4s and full-blown AIDS, C3, etc., etc., etc. So things did change, and did change in a very positive way. The second thing is that I'm in a men's world, very happy to be in a panel where I'm the single male, and also that Asia and the global world is here represented in Amsterdam and Europe. I was challenged to come here because I'm someone living with HIV, on treatment for life, and growing older. Well, I feel old for the last 23 years, so it's a little different. The impact on the body, to keep the subject, it's enough to look at me. I'm a kind of encyclopedia show of what was the Norvir, the first, the D4T, all these drugs that saved my life. And we used to say, well, they have plenty of side effects, but one of them is keeping you alive. So thank God for Norvir and D4T and the others, but I hope that the next generation will not suffer from these side effects. Where should I change this arrow? Okay, thank you. The second thing that I would like to say is that being someone from the community and being deeply involved in the work of my communities, I would say, the question of aging is in everybody's mind since we discovered the big change from being a dead disease, an emergency health situation, to a chronic disease, and mother, we seem to condemn to eternal life. So we need to learn how to live with a chronic condition. And the European AIDS Treatment Group had, which I did share some years ago, had a beautiful project, 3 years project on aging with HIV in the 3 cycles from till 18 or 16, the middle age, growing old, and the plus 55. I think that this was, the conclusions are there, but I think that we did really increase knowledge on HIV and aging, medical and related psychosocial aspects from this life cycle perspective. We also did identify and raise awareness regarding unmet care needs and probably unmet medical needs, as also identified previously for people living with HIV and AIDS. But we need, and I'm a strong believer, that we need to work in net. And that we do need collaborative efforts to advocate for the priorities of HIV in the aging domain. I must tell you that I'm a strong believer that the knowledge from the people and the different ages and the different cultures of the different groups that live with HIV, it's essential for giving answers. We have a problem regarding the inequity of the health systems around the world. And even in the so-called rich world, the inequity is not slowing down, it's growing up. And we believe that we need to convince the best of you around to put in the agenda that we will not have good societies if we don't have sustainable, equal health systems. And this is a huge effort. in a moment that I have my life, thanks to the discovery of the ARVs. And the second sense, you will see, I was also co-infected with HCV, and you still can see the damage in the liver. I also saved twice by medical innovation. But medical innovation, and I was a treatment activist and deeply involved in the research and development of the new drugs for HCV and safer drugs for HIV, needs to come at affordable prices for the different health systems that we have. It's essential that in this moment that we know that we can stop the transmission by treating everyone, and we can stop the disease by treating early and safely everyone, we need that our health systems are affordable and equal, and this, it's an appeal to my friends in the industry also. Another thing that we did and that we are also proud of is that we were deeply involved. And this is a very, European-centric initiative, but I think that there are many things that can be used from the HIV outcomes. That, again, as I said before, there is a collaborative process that captured the perspectives and expertise of people living with HIV, clinicians, public health professionals, and the wider HIV community. And these compiled recommendations that I wanted also to bring here in a way to see where should we move together in the future were presented in the European Parliament late last year, and I think that, again, what is this? Here. There was a set of recommendations that are here. Adopt and integrate outcomes-focused, and outcomes-focused is very important. We have in many health systems ways of monitoring the activity that are not based on the outcomes. And I can tell a small joke that if you are treated very well, you can go to your hospital and see your doctor once per year, and you go there twice to check if everything is okay. On the system that in my country the hospitals are rewarded, they lose money if they do very well. So this is the question of, and this was the little story to see how sometimes we need to change the perspective to also reward the health professionals, the clinicians, the public health experts for doing well and not just for doing activity. Because, again, and second small story, one of the things that I believe did change my perspective and my community perspective is that we wanted to be part of the solution. And to be part of the solution, we need to have the capacity to be active, to intervene, to work in the limit of our capacities, and for that we want to be treated as good as possible from the science point of view, from the medical point of view, but as active people for as long as possible. And there was this horrible tragedy of the friends dying that is still in our minds for a long time. Again, this was deaths at the time that were before the time that was foreseen for these people. Now we also want to learn how to die after an active life. I also think that one of the things that we need to reflect in our health systems is the question of quantity of life versus a single approach versus quantity of life and years of life versus quality of life. We can put this together, and it's needed to put this together because, again, in our system, health system, the efforts to keep people alive after a good life are tremendous. The cost of the last year of life in hospitals in Europe, it's horrendous. And most of us would want a last year with the family, with the friends, with not too much pain, etc. But this thing of keeping people almost artificially alive is something that we need to put in our monitoring systems because, again, my own country, we have enormously increased the expectancy of life. We were one of the worst in Europe 40 years ago or 30 years ago. We are now on the other side, better than the vast majority of countries. But the quality of life of our elderly, it's painful. So something needs to be also sought there. So long-term cohort studies, and cohort studies are very important and to have funding, and the funding is decreasing. But we also need in the cohorts to compare peers with peers or apples with apples. And I remember Professor Peter Rice saying that if you compare a cohort of HIV positive people in Europe with the normal population, you are not comparing apples with apples. We smoke more, sorry. Many of us did have process of drug use, like myself. We are prone to, so we need to distinguish and to have good science to know what is HIV, what is the treatment of HIV, and what is the cohort of people that are living with HIV. And we are very different from each other. This is stigma and discrimination is probably one of the things more difficult for me, because it's something that I still didn't find the way to tackle efficiently. We don't have good, in my opinion, still don't have good enough indicators of what is going on. We know that absolutely non-acceptable things are still going on. And I come back always to my country. 1 year ago, I had a friend, a woman living with HIV that used our facilities, that was refused to remove the contraception device in the healthcare system. And they said, no, we don't have conditions. And if you, 2017, it's impossible, this. And we need to do something, but really, I think that we need the best of you to think, how can we really tackle, erase, and monitor what is stigma and discrimination? And it's stigma and discrimination because of fear of disease, it's because of being in the key populations, it's because of everything. So it's something that I really hope that we find better ways to solve. And there is not answers to the HIV and the aging with HIV without the full participation of the community. That I'm also sure. So, I'm Portuguese, I'm 60 years old. I was diagnosed 22 years ago with AIDS, C3, 2 CD4s, HCV. I was dying, really dying. CMV retinitis in both eyes, one of them I don't see anymore, etc. My first treatment for those who can remember these things, was Norvir full dose, 3 times a day, because it was taken 2 times a day. But there was interaction with ganciclovir, so my doctor Kamal, who saved my life, put it in 3 times. So D40 twice, DDI twice, ganciclovir 3 times a day, Bactrin, etc., etc., etc. 10 intakes a day. So when I hear the difficulties of taking drugs twice a day, I think, oh my God, how difficult can it be? So, in the previous 5 years before, and this did not change completely, I was diagnosed. I crossed the healthcare system several times with herpes zoster, molluscum, pneumonia, alopecia areata, weight loss, extreme fatigue, candida, etc. And nobody proposed me a test. It was 96. But this happens. We see people entering the emergency room in my country and in countries all around the world with full-blown AIDS that did cross the health system several times. And this is something that we also need to change, because it will be much easier for someone who is infected with HIV nowadays if he's diagnosed early, and you'll have a quality of life and the capacity of life to do also an extension of life that it's forever, you will see. But it's very different from someone who is diagnosed really in the last minute. We can survive, but my friends that were diagnosed in the same situation as me in those days, there is only another one alive. Very good for me that I'm still here, but usually 80% of the people diagnosed in this situation die. And our health systems cannot escape possibilities to diagnose earlier. As you see, I'm 60, and what I wanted to finally say to you is that I had the most incredible 22 years. I did much more work than in my previous life. And I have assumed many responsibilities in the community, in EATG, in Coalition Plus, in GATT, in other organizations. I was starting to work on drug policy reform, something that we still didn't finish. We still didn't finish, and it's urgent that we finish the drug policy reform that the world needs. I started in 1984. So, other people will testimony the work that we have done. The second thing is that we need not to be complacent. This is the speech, this is the fear that I have more. That now that we are reaching faster or slower the 1990, that we have very good drugs, that we still don't have a vaccine, we still don't have a cure, but the rest is there on the table, that these drugs are very easy to produce. There is a complacency around the system, and it's not true. AIDS and the related epidemics of viral hepatitis, of tuberculosis, of STIs are very present. We have the tools, and if we can mobilize also the younger people and the brighter from you, we can really terminate ending AIDS in 2030. But I would like to retire before that. I'm entitled also to retirement. Thank you.
Thank you, Luis. And so you heard from our pediatrician on the panel, and now you're going to hear from our geriatrician on the panel. Dr. Eugenia Siegler is the Mason Adams Professor of Geriatric Medicine and Professor of Clinical Medicine at Weill Cornell Medicine in New York. She is the attending physician and medical director of the Acute Care of Elders Unit at the Weill Cornell campus of the New York Presbyterian Hospital. She also sees geriatric outpatients and serves as a consultant to the New York Public Health Weill Cornell HIV practice, the Center for Special Studies. In addition to care for people aging with HIV, her scholarly interests include documentation in the electronic medical record and medical education. After receiving her undergraduate degree from Princeton University, she obtained her MD from Johns Hopkins and trained in internal medicine at Bellevue and New York University hospitals. Following her residency, she did her fellowship in geriatrics at the University of Pennsylvania, and we're really happy to have Dr. Siegler do the last 20 after we've heard already the first 20. Dr. Siegler.
Thank you. Luis, you're a hard act to follow, but you're also the perfect act to follow. I have a disclosure. What I'm going to do today is just give a little bit of background and then describe some programs that I've been able to find and some lessons that I've learned from that. The first is just a little bit of epidemiology, and this is a graph from 2014, from Mayhew's study in 2014. The top graph is describing the number of people over the age of 50 with HIV in different countries. The blue represents Western and Central Europe, and green Asia, and so on and so forth. The graph begins in 1995 and ends in 2013, and you'll notice that there's an inflection with a greater rise in the number of people with HIV who are over 50, even for populations that have low numbers, so that the inset on that top part shows Caribbean and Middle East, where the numbers are small, but the inflection still is there. The other important takeaway from this graph is graph B, which describes the population in Africa. And in particular, when you see the blue line, which reflects southern Africa, you'll notice that the y-axis is at a different scale, so that by 2013, 1.5 million people over the age of 50 were living with HIV in southern Africa, and it's now 5 years later, and we can only anticipate those numbers are higher. So this is a worldwide phenomenon, and what we're trying to understand is how best to meet their needs. There is no evidence base for this, and so I did what I guess anyone in my circumstances would do, was once PubMed didn't come up with much, I started to Google and email and just try to find any contacts and any information that I could. I followed up on referrals of referrals. I did not include intervention research or prospective cohorts. I wanted to look only at clinical programs designed for people aging with HIV. What you'll notice here on this PubMed search is entry 2, which is a program for geriatric HIV patients, and that was a program in New Orleans. This study came out in 2010 describing their experience in 2008 and 2009, and this, by a geriatric standard, was a dream team. This was perfect. This had a geriatrician, this had a pharmacist with geriatric training, a social worker with geriatric training. There was a screening process that evaluated all of the geriatric domains: functional, physical, affective, social, and there were specific criteria for referral. People with more than 3 problems in any of these domains then were evaluated, and there were very specific therapies or interventions for those identified needs. This program no longer exists. It folded when its founders left the institution, and there was not enough institutional support to continue it. When I spoke to the chief of ID, she said that it had a legacy. It had a legacy in terms of the programs that they continued. They continued social work, running the team meetings. They have instituted palliative care, and they have instituted neuropsych programs, so that there was a long-lasting effect of the program. But the fact was that there is no guarantee that these programs can continue without strong advocacy. What I'm tried to do is divide the various models I found into basic groups, and these divisions are somewhat porous. This is my first draft, but the first model that seems to be fairly common is a classic consultative clinic. You'll see that 5 of these that I found are in the States, 2 in Britain, 1 in Canada, and they vary by different parameters. Some are biweekly or monthly. Some are separate multidisciplinary clinics. Some have a single geriatrician doing a consultation. Others have teams. But all have as their model that someone is referring an individual to that clinic or to that person for an evaluation. The advantage here is what any geriatrician would say, is that it's a geriatric frame of reference. It tends to be very broad. These use comprehensive geriatric assessment, and the kind of evaluation looks at the patient's biopsychosocial needs very, very broadly. The disadvantage is that these are consultations, and therefore what one may recommend does not necessarily mean that those recommendations will be followed, nor is there any guarantee that the referring physicians or referring clinicians learn from the consultations and perhaps change their way of caring. The second kind of program that I found were programs that had evolved from existing programs. And I found 3 programs that had long-standing metabolic clinics that began to recognize that frailty and sarcopenia and other geriatric syndromes were having increasing prevalence in their clinics, and started to evaluate and respond to them. These programs tend to be very comorbidity focused. They have often established protocols for comorbidities, and so they've added the geriatric syndromes and other problems on top of that. The great advantage here is that, of course, these concepts and these age-related syndromes are internalized, and the major disadvantage, though, is that because of the comorbidity focus, it takes a lot of energy and effort to remain involved in looking for psychosocial problems and making sure that all the patient's needs are being met. There's some developing programs, and here in a number of places in the world. Some of them appear to be headed toward one of the main programs that I've described before. Some are programs that are evolving from cohort studies, and I think that's very exciting because the studies have demonstrated to their PIs that there's a need, and they're making changes in their clinical programs to reflect those needs. Many of these programs are starting small with geriatric evaluation, and that is a way to start with minimal resources. It also can be done without a physician. The main concern with these is that if there are no interventions that are linked to the evaluation, you've done screening and you've identified problems, but you haven't provided any solutions. So screening and interventions have to go hand in hand, even if the screening is very focused. what we also have recognized is that so much that happens with people who are aging with HIV is happening outside the office, and that as physicians and other providers we're office-based, but that's really not going to reach people where they need to be reached. So these are a couple of IT-based programs that are putting more in the hands of people who have HIV. The first is an app, and it's understudy called mysmartage.org. In this app, there's two-way communication. The person with HIV is inputting data passively about their health and number of steps they're taking, but also actively in answering questions that are being sent to them. On the reverse side, there are coaches who can answer questions or provide information to them. Right now, there's a feasibility study just trying to determine, can we detect frailty? Can we figure out how much people are moving, what people are doing? And if so, then can we determine interventions that can help individuals become more fit? The other technologically based intervention is one that's just about to be launched in France, which is a virtual passport where, based on the French national HIV guidelines for screening and exams. These are age-based. And again, the idea here is to empower the individual to know what their medical needs are and what's indicated, and to give them the opportunity to take some control over how they're going to get their care. One last model I want to bring up, because it again reminds us of what we need to think about, is in Hong Kong, where the center of the model is case management, not the physician's office. And that, again, reminds us that although we are medically based, that's how we're trained, that's what we think of, that's what we've researched, that's not what the individuals we're caring for are. And so this case-based model is reminding us that there have to be many other venues and many other things that we need to think about aside from comorbidity. So having just reviewed what I found out there are several things to think about. And one is that we really haven't addressed the differences between resource-rich and resource-limited settings and what they need. What we know in our resource-rich settings is that our goals are the way we view quality of life involves maximizing function, limiting frailty, fine-tuning comorbidity management, and preventing polypharmacy. Resource-limited countries have much more fundamental problems, which may be ensuring access to subspecialty care. In addition, for many, especially in resource-limited countries, the linkage to HIV care is the linkage to chronic care. And there are lessons that perhaps resource-rich countries can teach resource-limited countries about establishing protocols or determining which comorbidities are the most important to focus on. But there is a lot that those in resource-limited countries can teach us about linking to the community and taking advantage of community resources. So while the structure and goals of various programs may differ, they pretty much all share common barriers. The first five are lack of money. Lack of expertise is also a problem. There aren't many geriatricians in the world. We don't quite know how to target. Do you target people over 50 so that you can talk to them before they have aged? Or do we target only those people who already have extensive comorbidities? We don't know what our outcomes should be. And for all, again, there are inadequate social resources. So we have no best practices. We're trying to learn from the challenges we face as we build these programs. I've organized these challenges or the questions that we need to answer into these 6 categories. The first is referral. Again, is it age-based? Is it comorbidity-based? Do we choose people who have functional impairment? Who's going to be screened, and how are they going to be referred? What are the tools we're going to use? Research assessment tools are very different from clinical assessment tools, and often we have to choose things that are very simple so that they can be done. Where is it going to be? And who's going to be staffing it? One of the clinician-based programs that I mentioned is managed by an NP. You don't need doctors necessarily. You do need people with expertise in aging. What is the focus going to be? Is it going to be on disease management? Is it going to be comorbidity focused, or is it going to be functionally oriented or focused on community-based problems and improving supports? And what are the outcomes? What are our criteria for success? Geriatricians do not generate income. Geriatricians are often dealing with people who need palliative care, who do not have lengthy lifespans. We have to decide what success is. And finally, linkages. And the initial linkage that I discussed was the linkage between a consultative clinic and primary care, but there are other linkages to community organizations, but also something that I haven't talked about, but we need to think about quickly and seriously, and that is long-term care needs. People are in their 50s now, but when they're in their late 60s or 70s, they will need long-term care. And how do we establish those linkages in ways that are respectful and don't exacerbate problems of stigma? So I want to end by thanking everybody who emailed me. I have pen pals all over the world now, and this was the most exciting and interesting part of what I did. And some references for those who want to do further reading on the projects I've discussed. Thank you.
So thank you very much to our 3 panelists. We now turn to what is going to be quite a brief panel discussion, actually. Unfortunately, one of our panelists has not been able to join us. We weren't aware of this until we came into the room. So I'm very disappointed to say that Lois Maturo, who is a brilliant young woman from Zimbabwe, born with HIV, is not going to be able to join this panel discussion. I'm hopeful that as we get into the Q&A session from the audience, there may be other young people born with HIV who will be able to share some experiences at that point. But at the moment, it's the panel discussion, the shortened panel discussion is going to consist of myself, and also Sophia. And we're going to start with Sophia. Sophia Wyden is from the Netherlands. She's an advocacy officer at Pharma Access, which is a Dutch non-for-profit organisation working to improve healthcare financing and delivery in sub-Saharan Africa. Ms. Wyden handles partnerships, conferences and other advocacy activities at Pharma Access. Prior to this, she served as country manager for Sweden at Access Health, which is another non-for-profit organisation dedicated to the improvement of healthcare. At Access Health, she oversaw the growth of the Swedish office, and she wrote over 30 case studies and published 2 books on the topic of ageing and innovations in healthcare, together with Professor William Hesseltine, who's a renowned HIV researcher. These studies focus on care models that support older individuals living with chronic illness. Ms. Wyden holds a Master's of Arts in Economics and Politics from the University of Edinburgh. And she holds diplomas from the University of Richmond in Virginia and the Sorbonne in Paris, and from Gothenburg University. So, Sophia, off to you, just to give us a few brief reflections on what you've heard this morning.
Sure. So we've heard some quite terrific presentations. And for me, what I keep on hearing from my fellow panelists is the need to really look at the entire person. So treating or supporting the person and not the illness. Whether you are young or old, we see there are quite a lot of different comorbidities and lifestyle-related health problems. At the same time, we have built our healthcare systems in a quite siloed manner, where one of your, illnesses is managed over here at the university hospital, maybe by your HIV specialist. Potentially one of your other comorbidities could be your liver failure, or renal failure is managed over here by another specialist. At the same time, you go for regular checkups to your GP over here. You might have some social care, say, over here, and all of this needs to be somehow integrated. And so I think what we need to think a lot more about in the future, as lifestyle-related health issues are increasing, and as we know, when you are living with HIV/AIDS, you are much more prone to comorbidities, that we integrate. And if we cannot integrate, that we at least coordinate. And what does this mean? I mean, it really means, hopefully in the future, sharing a lot more data, working, as we've learned from Dr. Ziegler, in a much more geriatric way of thinking, where team-based work, collaborative work, is the cornerstone of the health management approach, where the nurse, the home care nurse, might be just as important as the HIV specialist. And I think it also really means to redefine our measures of success, to listen to what matters to individuals. A well-managed HIV status might not be so problematic as, say, your diabetes. In your everyday life, your diabetes might give you more health issues and might prevent you from doing the things that really matter to you. So I think redefining and broadening our measures of success, and really listening to patient feedback. And really, I think the last point would be to use new technologies. While we can, today we might do an annual kind of medication checkup, we might do biannual controls. With new technology, we can interact almost on a daily basis with people. We can gather patient feedback after every appointment, and we can really tweak our interventions and our support and help individuals to manage their chronic illnesses at home in a much more efficient way, and I think person-centered way. So I think I'll stop there. I have, of course, a lot of other comments, but we can open up for the panel discussion.
Thanks, Sophia. So, yes, I have to make an admission that I usually try to avoid any sessions in conferences that are talking about HIV and aging. And that's because if I read anything on HIV and aging, or I come to any sessions, then I get deeply paranoid about what might be going on in my body, and I'd rather put my head in the sand most of the time and not actually think about that. But this has been a really fruitful and great panel, I think. As someone who has lived with HIV in my life through quite a large chunk of my life cycle, from my early 20s till now my late 50s, I can very much, a lot of what Louise was saying was chiming with me, I think, having been someone that has had to really deal with the D4T and other problems and challenges that we had in terms of treatment that kept us alive, and various comorbidities and so on. But I think, as Sophia's already said, and we've heard so much, I think one of the things that comes across so clearly, whether we're talking about one end of the spectrum or the other end, it is the need for a person-centered approach, and an approach that really is looking at and treating the person in a holistic way. I think I was in a session yesterday where we were talking about 30 years of activism. And there was a reflection that post around 1996 in the Vancouver conference, we saw an increasing biomedicalization of a lot of the response. And that came for obvious reasons with the push towards treatment access. But with that, which was a great thing, there was also a letting go and a deprioritization, if you like, of some of the other key elements, which we've heard a lot about here. The need for a multidisciplinary, cross-cutting approach that's really looking at the whole person. And one of the other things I think that Louise and others refer to is really, it's about what we used to call the GEPA principle, the greater involvement of people living with HIV. It's really having people, whether they're adolescents, whether they're older people living with HIV, at the center of how programs are designed and rolled out, and being able to give that real-time feedback, whether it's through sort of mobile technology, community-based monitoring, and so on. But really, for people living with HIV to be working hand in hand with providers to ensure that the services that are being provided, are meeting those needs and flexible to the evolving needs and the evolving science and progress that's being made. And just also, and to note that I think one of the things we've found at the Global Fund, we've been doing some research with young people living with, born with HIV, but also young people who aren't living with the virus. And one of the things that we're finding is, for them, HIV isn't necessarily the main issue that they're concerned about. They might, health might not be the main issue. It might be jobs. It might be other things. For those of us who are aging, it might not be HIV per se. For me, it's been menopause for the last few years, and there's not a lot of research around that as well for those of us who are living with HIV. So it's important to, for us to be able to, to locate, HIV within the other issues and priorities that people are facing. For many people, it might just be getting food on the table for their kids. So I'll stop there, because I do think it's important that we have some time for all of you to have a dialogue with, with the speakers and panelists here. So I'll hand back to Michael.
So we'd like to open it up for discussion. There are microphones in the center, and we call on your microphone, if you could please introduce yourself and the country in which you are based. Microphone number 1.
Hi, David Miller with Panaware in the United States. And coming from a perspective of both being a treatment activist and a patient and epidemiologist, I'm really confused. Maybe you can clear this up for me. There have been 15 peer-reviewed publications in AIDS, Journal of AIDS Care, and a dozen other high-impact publications that all the KOLs and program leaders should or could be reading, because their institutions subscribe to them, on the emerging epidemiology of persistent comorbidities that are affecting GI inflammation in HIV patient populations. Crohn's disease is significantly on the rise in proportion to the general population, probably because we're living longer. Dysbiosis still doesn't have a real degree of address. The vast majority of clinicians still aren't using Mytesi and are continuing to give us Imodium, even though that's not what is approved by the FDA. We have more and more GI comorbidities. And yet at this conference, and at CROI, and at IDSA, there are no dedicated GI sessions. So I'm wondering how many demonstrations or consensus statements we need to do till we get the KOLs to change that. I'm just looking for the number.
I don't know if I could give you that number, but maybe Dr. Siegler, could you comment on GI conditions that you see in your clinic and how that balances out in terms of trying to provide holistic care?
I think there are two questions here. One is why isn't it being brought up in this kind of meeting? And obviously I don't have control over that, but what I'll say is I could have the same concern about the absence of discussion of HIV and aging as well.
Mm-hmm.
So let me just say that I'm with you in terms of having a shift in what is discussed and the populations that are covered. What I'll say is that as you've heard here, the comorbidities often eclipse HIV care as a source of concern and as how we spend our time. If you were to ask me as a consulting geriatrician, are people sent to me for GI problems more than other problems? The answer is no.
Right.
But I think the bottom line is whether it's GI or cardiac or renal, we have to address each of these both individually to understand how people who are aging with HIV have different manifestations of these diseases, and we have to address them collectively so that we can respond. And for example, for people who have GI problems as their primary concern, have the facilities and the expertise available to help them.
I appreciate that. Just one follow-up. Do you think it would be justifiable to start exploring the geriatric GI clinical investigations that we may be needing in the very, very near future?
I think that it's always justifiable. What's interesting is that GI in classic geriatrics, the GI tract doesn't change as much as some of the others. So maybe one of the problems you're seeing is that the geriatric research world doesn't appreciate what the HIV world is seeing and need to be brought up to snuff.
Thank you.
Thank you. Microphone 5 and then 2. We'll take 2 questions and then respond to both.
So thank you very much. My name is Dr. Adetiloye. I'm a public health physician. I'm with Japaigo from Nigeria. I want to thank all the panelists, particularly the first professor from Thailand. And I particularly like the fact that this panel talks about pediatrics, geriatrics, all put in one together. So one area I would like to hear more from is we've talked about integration, NCDs, mental health, all those ones need to be integrated. One particular area is the mental health. I want you to share an experience you have, maybe in the developed world. Are there programs whereby the mental health is really integrated into program, not only for HIV, because I know this always is it's a standalone program which is in silos. So if you could share an experience where you have mental health being incorporated or integrated into a program, that would be very useful for me. Thank you.
Thank you. Microphone number 2.
Sorry. Thank you for the panel. It was really, really important. I'm the head of nutrition of the World Food Programme of the United Nations in Sub-Saharan Africa. And I have come a long way to here to learn from you. In the programs where I'm working related to HIV, the beneficiaries are screaming loudly about the support for food security and nutrition. The Copenhagen Consensus clearly stated a few years ago that for $1 invested in nutrition, there are $18 of return of public health. And the SDGs include food security and nutrition, SDG number 2. So my question is, why in large events like this one, like in the AIDS conference, I could only identify among the main sessions the presentation from the professor from Thailand, in the presentation number 1, some evidence on the importance of nutrition in HIV. What are the barriers? Is it funding? Is it the decision makers not really understanding the multi spectrum of nutrition? Thank you so much.
Thank you. So we'll take some answers for those before we go to microphone number 1. So about the integration of mental health into programs, Sophia, do you want to comment on that? And Luis, and then on the nutrition question, have Tanya Wee and Kate from the Global Fund comment. Sophia?
Yes, so I might want to refer to my colleague, Dr. Siegler, also because I'm not familiar with all the in-depth details of the programs. Of course, we've realized that we need to really think about integrating mental health into these programs. We must move beyond, of course, just screening and primarily really consider the quality of the mental health and not just say mental health counseling or some sort of access to a mental health professional, but what is the quality of the mental health in these programs and what is the level of integration? I think that will be something very, very important to consider for the future, and especially in the sphere of aging, where we know that isolation plays a big part, where loss of your network as you age, ageism, age-related stigma on top of the HIV stigma, depression, of course, is a big reoccurring element. So I can't comment on any of the details where mental health has been fully integrated. I can just sort of reaffirm the importance of it.
Luis, or Dr. Siegler, do you want to comment first, or Luis? Okay.
But then I will pass to you. I think that the questions of mental health are fundamental, I would say, everywhere. It's difficult to adjust. There is a kind of mental health questions that need the best knowledgeable possible. But there is also a kind of confusion with happiness. And happiness, usually we think that it helps a lot in the mental health conditions to give food, to give support, to share a glass of wine. I don't know if in the new things can go well. So there is also a part of the psychological condition that we should study more and that can have a huge impact before we arrive to depression or to other serious mental health issues that need specialized care. But so this continuum, I think that the task shifting and insecurity is very important to prevent some of the morbidities that we see more in the mental health.
I'm very lucky in that I'm working within a program that it has 4 psychiatrists. So what is missing, as usual, is the community-based support for people who always need more than medication to function. Let me also link the food question with the mental health question and put in a plug for a survey that's underway now called ROA, Research on Aging and HIV. This is its second phase. This is run by ACREO, which now is a part of GMHC and is surveying people with HIV over 50 all over the country. And its strengths are going to be looking at a variety of mental health issues, also looking at food insecurity, and I think it will provide data to make a compelling case for more supports for both nutrition and mental health services. One other point I'd bring out is certainly in resource-rich countries, oftentimes obesity is the major nutrition problem, not food insecurity. And so let me broaden the issue to say that there problems with nutrition are everywhere. But food insecurity is only one part of that, and we need to look at how improving nutrition can help health and how we can give people access to good food, not just food.
Tanya, Dr. Tanya.
Thank you for the comment, because I think that I would like to to see that we have more focus on nutrition and also other aspects while we're taking care of children and adolescents for any diseases. And I think in the past, it might be because we are in the survival mode. We just make them alive. And now it's time to talk about quality. So I think we should work at the different level. From the UN, can UNAIDS and UNFDP work together? And at the country level or at the clinics? I think we need integration.
Hi, just a couple of things. First, on the mental health question. I think one of the biggest issues that I've noted with communities that I've worked with across the world is the stigma that's attached to global health. I mean, to mental health. The stigma that's attached to HIV itself. But in addition, I think many people find it very difficult to come forward and actually own the fact and that they are having mental health issues. I have many friends and colleagues across the world, particularly who are getting older, who are really dealing with a lot of mental health issues, but not able to articulate, or comfortable to. And I really liked just to say, I really liked a lot of the very practical suggestions we had from the speakers anyway. But I think the example of the grandmothers, I think, was really great to look at how we can task shift and make those discussions like really kind of real and possible at the community level, particularly where there are not a lot of resources. On the issue of the food security and nutritional needs, yes, absolutely. I mean, I can't count the number of times that people have said to me, "Well, it's great, I've got my HIV meds, but I have not got food on my table. I can't feed my kids. I can't feed myself. I can't take my meds on an empty stomach." And those of us living with HIV know how horrible it is to have to take your meds on an empty stomach, the few times that I've done it. So I think it's, and it is partly about, how things get funded and the quite siloed approaches that we have sort of, inherited from the MDG era, I think. And as we look, as we're now in the SDG area, we are, I hope, moving towards much more comprehensive and integrated approaches where we're understanding and acting on the understanding that there are so many different elements that we need to be covering, whether it's whether it's addressing gender-based violence or education or linkages or comprehensive sexuality education. All these different pieces are absolutely critical. Now, how they get discussed at country level and funded at country level and planned for at country level can be very tricky, because you also have the silos at country level in terms of ministries and the way that things are planned in terms of health and other parts of other sectors.
So the last two questions, microphone 1 and then 2.
Thank you. Richard Harding, King's College London. Thank you, Lewis. You made the really important statement that people don't want to spend the last year of life in hospital. They want to be at home, pain-free, with friends and family. The facts are we have 1 million HIV-related deaths each year. We have ageing. There's a review in the Lancet HIV this week showing that palliative care for people with HIV improves outcomes and saves costs, and the new universal health coverage goals state palliative care for all. Yet the curious thing is there are no abstracts here this week on palliative and end-of-life care. Community rarely speaks about it. So what can we do about that?
Thank you very much. And question number 2?
Yes, thank you for your presentations. My name is Emilia. I live in the US, but I work in Nigeria. I work with a lot of adolescents and young people living with HIV. As we talk about comorbidities and supporting children as they grow up, when they outgrow OVC programs, a lot of them are facing difficulties staying in school. Many of them are dropping out. We can't support them anymore with school fees. So as we deal with these children and when they get to young adults, we need to also consider supporting them so that they can be able to max out their lives. Because if they don't remain in school, then we have other problems. Thank you.
Thank you. So first, maybe Dr. Siegler, then Luis, and if Sophia wants to add anything about this issue of palliative care, how we can get it more integrated into the conference, and the importance of it in HIV end-of-life care.
I'm not quite sure what to say because, of course, I'm in agreement with you. I think that the need to bring in more research and symposia about all of these issues is clear. Palliative care is, I think, slowly infiltrating the subspecialty societies, for example, oncology, obviously, and renal. And I think that my experience with HIV is that some of the that we could, just as we've used the models for geriatric care in the subspecialty societies, we should use the models of palliative care in the subspecialty societies. So there's geriatrics could serve as a model of how we take what we have learned and apply it. The key thing is recognizing that the first step is to figure out how what they know for the general population applies to the subspecialty, and then translate that to HIV. So I think the answer is, of course, it belongs. Geriatrics belongs, but palliative care can use the model of saying, okay, this is how I infiltrated the oncology world, and I'm going to use those same techniques to infiltrate the HIV world, and I think it will work.
Luis, do you want to add anything?
Well, things did evolve, and it's strange in a certain way that we were facing a debt crisis in the 80s and the 90s, and things evolved very quickly to chronic condition, etc. But the obsession with the fear of death, and I would say unfair death, was so big that now we have the opposite difficulty, that is talking that every human being one day will die, and that our civilization is losing somehow part of the knowledge that was accumulated in many civilizations about dying. And really, I find even with my friends, sometimes when I push this question about this terror of dying in hospitals, etc., and knowing that you will be dead, that some people, an additional year of life or 2 years of life, etc., it's no gain except suffering for everybody involved. But it's a very difficult topic. We need help also to put these things in the agenda. And there are very ethic dilemmas, very important ones that we cannot escape from making together. But that's the answer I have. Something that, and sorry, just another phrase. Last 10 years or 15 years, I have struggled with the sustainability of the health systems. You know that Portugal went bankrupted, blah, 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 blah. And this is a key problem for the sustainability of our health systems. And we are denying basic, good health care or specialized interventions to maintain a model of governing the health systems that is only based on this process of end of life. So I think that we need to work together, probably. Thank you.
So I'm afraid we've run out of time, but I encourage those of you who want to talk to our speakers to come up. Thank you all for joining us, and thanks to our speakers and panelists.